Thank you, Anne and Peter, for being here with us. Before starting, will you just briefly introduce yourself?
Okay, I'm Peter KINDERMAN. I'm a professor of clinical psychology at the University of Liverpool in the UK, and I'm one of the authors of this report.
Okay.
And I'm Anne Cooke. I also work in a university in the United Kingdom, Canterbury Christchurch University. I work on a training course training clinical psychologists for the British National Health Service, and I was the editor of this report.
Okay. Actually, this is the reason why I did try and contact you, and I managed to contact you. Just could you explain the reason behind this report, which I believe is a very important report for the UK, for the US, and possibly, I don't know, for Italy as well?
Yes, certainly. I think it was about enabling a more helpful story to get out there about psychosis and schizophrenia, because I think people think they know what psychosis and schizophrenia is. They think that it's a serious brain disorder that's lifelong and needs control with medication. And actually there's been a lot of research in the United Kingdom recently that shows that it's a lot more complicated than that. For many people it's possible that it's not a brain disease at all, that it's a result of things that happen to us in our lives that result in us, for example, hearing voices. So it was really to bring together that research and in a way that people could understand, both people like you journalists, people who contribute in some way to the debate in public about these issues, but also people who are personally affected, who, for example, hear voices, their friends and relatives, and also professionals, because a lot of professionals haven't come across these ideas either.
So what are you proposing with this report, with the outcomes that you've managed to gather in this report?
Well, we think people should be a lot more open-minded and possibly a little bit more questioning about some of their assumptions. So as Anne says, the usual way to think about schizophrenia is that we know the answer, that we know it's a brain disease, and that we know people need to take drugs. And we're suggesting that people are a lot more open-minded than that. Each person's story is very different, and each person's solution is very different. So, for instance, while drugs might make sense for some people, and while thinking about schizophrenia as an illness might make sense for some people, other people don't see it that way, and we shouldn't force one way of thinking about things on people, and we shouldn't force them to accept only one form of treatment. We need to be a lot more flexible in the way that we approach these things.
Yes, the main message of the report, really, I guess, if there is one, is that, and this is a quote from the report actually, is that professionals shouldn't insist that people accept any one framework of understanding. For example, we shouldn't insist that people see their problems as an illness, or in fact that they see their problems as some kind of psychological thing, perhaps a result of trauma, because different things can be involved for different people and different explanations help different people as well. And in fact we don't know. All we actually know is that people say that they have experienced certain things like hearing voices, and that and sometimes we see people behaving in certain ways. That's really what everybody knows. We don't actually know the causes of those things. That's our interpretation, and there are various interpretations. The traditional one has been it's something going wrong in their brain, but actually we don't know. All we know is what we see. So I guess the message is that professionals need to be a bit more humble, really.
And when we sit down and talk to people, quite often their stories do make sense. Mm-hmm. So each story is different, but you have people, I mean, we're in New York City, you have people who are stricken by poverty, living rough on the streets. So for those people, making sense of crazy things happening in their imagination, it's not easy, but it's often possible to sit down with people and for each individual person work out a story that makes sense for them. Sometimes that involves traditional psychiatry, but sometimes it's a much more human story than that.
How was to present this report here in the United States, in New York City? We all know that, the United States, the approach in psychiatry is mainly organic. It is drug therapy, and that's it. Nothing else really. How was your experience with that?
I think it was very positive. I think that some of these ideas, like you say, they are newer here. I think a lot of the research that we report in our report has been done in the United Kingdom. Psychologists in particular have been very active in researching into a psychological or a psychosocial approach to psychosis in the UK. So it's newer to a lot of people in America, in the United States, but judging by the response that we got yesterday, they were really happy to hear it, and it really made sense to them.
Yeah. But actually, we were just talking about the fact that the New York Times just mentioned these reports in the paper, which is, a big event. I mean, it is quite really relevant. So what do you think are the reasons behind all this interest in the United Kingdom, but also here in the United States?
I think there are a number of reasons. Partly it's research, so we understand, I would say we understand a little bit more about some of the things that lead to these sorts of experiences. But I think it's also fair to say that citizens themselves are finding their voice. So in the past, stigma and discrimination have meant that people who are users of mental health services have either kept quiet or been kept quiet. And now a lot of people who are themselves users of mental health services are saying, I need to sit down and talk with somebody. I need to work with somebody to find out why I've experienced these problems and what can help. I don't want to be diagnosed with illnesses and given drugs. I want something more than that. And so the citizens and the consumers are starting to stand up for their rights. And those two things are coming together. The people are demanding better services, and the researchers are saying, well, we have alternative ways to understand these problems. And that's coming together in a very positive way.
How do you think the outcomes of this report are going to affect the treatment paradigm?
Well, I mean, I think in the UK we're starting that process. So the National Health Service in the UK is making some major investments in offering people psychological and psychosocial approaches to their problems. So we're trying to train people in psychological approaches, and we're making standard settings so that people in receipt of services can expect to receive psychological approaches if that's what they want. And that's hard work. We need to train people, and we need to change the way that services are delivered. But to be honest, there's some support even from government for pushing in that direction. So I think we're starting. I mean, what we'd like to see is more of that, really, and more of those sorts of services available in the US, and more of those services available in Italy too. There's a lovely phrase that some of the people, the activists in this area, are using, which is, don't ask me what's wrong with me, ask me what happened to me. So traditionally, when people are presented to services very distressed, then the question is, what's wrong with this person? What's ill about them, or what's disordered about them? What's the pathology inside them, especially the brain pathology? And the phrase, don't ask me what's wrong with me, ask me what's happened to me, is aimed at finding out the story that people have, the reasons, the things that have happened to them in their lives, the important things that have happened to them that might have led them to be very distressed, to have some unusual experiences. And often there's stories of racism, of discrimination, of domestic violence, of bullying, of sexual abuse, of poverty. People have their stories, and so it's important, as Anne says, to shift the ethos from seeing the problem as lying inside the person, the problem as lying inside their brain, and start thinking about the problem as being to do with ordinary human beings living complicated and difficult lives, and how we can respond to that, how we can understand it, and how we can help them.
Okay, thank you. We were also discussing about the topic of this Congress, and we said, okay, it was all focused on understanding patients' experiences, but then we wondered, then what's next? Okay, it is important to understand these experiences, but then what are we going to do? What psychiatrists are going to do to cure them?
That's important, but there's more. So because we know, not only in psychosis, but other mental health issues, that the experiences people have had in their lives are probably the most important factor leading them. So we need to look at how we protect children against abuse. We need to look into our schools to look at bullying, so people can be dramatically affected by bullying from their peers. We need to look at domestic violence. We need to look at children being exposed to abuse and exploitation as children. We need to look at poverty, racial discrimination, homophobia, bullying of all kinds. We need to think about how not only do, as you put it, how psychiatrists cure people. That's only a tiny part of it. It's important, but it's a part of it. We need also to think, if we understand properly why people end up being distressed, unhappy, anxious, afraid, with low self-esteem, then we would do a whole range of things differently. We would protect children differently. Yes, we'd provide people with more therapy and less drugs. We'd do a whole load of things differently.
It's sort of promoting a new culture.
Yeah, that's good. I like that. I haven't heard that phrase used of what we're trying to do, but it makes sense, doesn't it? Yeah.
We were discussing about the fact that, psychiatric hospitals were closed down in Italy, as you know, also high security psychiatric hospitals will soon shut down, and there are no territorial services for these people. So patients are left on their own, their families are left on their own. It's just like saying, okay, this is your problem, this is your issue. Then, how can we promote a different culture? How can we help these patients be treated and cured, whatever? If this is the approach, this is in Italy, but I've read the report that I showed you, which was issued on the New York Review by Oliver Sacks. It is also the same case here in the United States. So how we...
Yeah, well, it is, people need care. And there are, one of the criticisms of our report has been that perhaps some people feel we make light of psychosis in a way, that we don't acknowledge enough that for some people these problems are very severe and lifelong. But in fact, we've kind of done that on purpose in a way. It's not that we haven't acknowledged, but we felt that there was a balance that needed to be redressed, that for a lot of people do get better, and they do, in fact, most people get better. However, there are people who need a lot of help, and I think it is, it's a shame when it's bad that help is taken away, especially when there's nothing else in place. But I think there is a question about whether hospitals are necessarily the best place for care to be provided anyway, because we're not necessarily talking about a health problem.
Yeah, I mean, it's true. We're talking about a big agenda, and I think that not only in this report, but I think more generally all of our colleagues in psychology and psychiatry and nursing and social work would echo the view that as civilized societies we really do need to invest in the mental health and psychological well-being of citizens. And yes, it's a big job, but it's almost like it's an infrastructure problem for a nation. If we invest in the mental health and well-being of citizens, especially young people, it's an investment.
Yeah, it is.
So depression, whether you like that word or not, but mental health problems more generally are the main cause of lost productivity at work. If we had a psychologically healthier workforce, that in alone would pay back dividends in terms of the investment that we put in. When people are off work for many years because of serious mental health problems, they're not contributing to the economy. They're a drain. Yes. No, not a drain, but it costs us money to support them. So proper investment.
Very British approach or American approach. This is something that Italians are not used to think about.
It's a humane approach.
A humane approach. Okay, that's interesting.
It's a civilized approach.
Okay, good point. Good point. Can we just say that at the end of all this, we can surely say that current psychiatrists or current psychiatry has acknowledged failure of organic approaches?
I wouldn't say that it's failed, that drug approaches in particular have failed, and that's we don't say in our report.
Only.
Yes, exactly.
Only.
We don't
Only.
exactly.
Only.
We don't say that people shouldn't take medication. It's more...
Maybe I expressed myself wrongly. Just say only. Okay, just focusing only on this can be regarded as a failure.
Yes, that's right.
Yeah, so the point of view of identifying illnesses is one perspective. It's a perspective from psychiatry with a great tradition, and it has its place. But it's not the only way to think about these problems. And medication, psychiatric drugs help some people, but it's not the only way to treat problems. And to think of, to study how the brain works and how problems with the biological functioning of the brain might contribute to our mental health is a perfectly valid thing to do, but it's not the only way to look at things. So if there is a failure, it's that we've been too blinkered.
Yeah.
And what we're saying in the report is we need to have at least a plurality of approaches. We need to at least look at people's mental health from all perspectives, and each individual should choose which approach makes best sense for them.
And also in your report, you're not suggesting that a psychotherapy is better than another. For example, cognitive behavioral therapy is better than psychodynamic psychotherapy.
No. Cognitive behavioural therapy is the most researched therapy, and so there's most evidence for that. However, that doesn't mean to say it's necessarily better, and certainly it doesn't mean it's better for everybody. The message of the report is that different things suit different people, and in fact, rather than taking kind of expert advice of this is the therapy that works for schizophrenia, actually it's similarly with the drugs. Actually, it's a case of different things suit different people, and people should be able to try. And also, and it's a very different culture, that trusting that the person themselves is the best judge of what's helping them, both in terms of drugs and therapy and therapist actually. And so it's a question of them trying until they find somebody that they feel that they can talk to and is helping them.
Okay. We were also saying about stigma, how it is frightening for patients and for people as well to speak of schizophrenia. And we were discussing about the fact, is this just because it is so frightening, the word itself, because, it just opens something that is unknowable? Or is it also because patients have got the feeling that there is no cure, that if they are diagnosed with schizophrenia, they are sort of doomed?
Yes, in fact, we had a quote in our talk yesterday from somebody called Johnny Benjamin in the UK, who said that when he got a diagnosis of schizophrenia, he felt like he'd been given a life sentence. And I think there's a big issue, because there's two things. There's the story that's often told within services, which is you've got a lifelong illness, which is obviously very frightening, and especially if you're also told, people sometimes get very messages which knock their confidence, like, I've come across people who've been told don't expect to work again, and that can become a self-fulfilling prophecy. So it's changing that. It's that story within services, but also more broadly.
And I think one of the things about psychotic experiences is they're often described sometimes by artists, by movie makers, as well as by psychiatrists, as completely alien, non-understandable phenomena. There's no way that you can understand them. These are just bizarre symptoms of an illness. And I guess one of the messages also from what we're saying is that if you take the time to sit down and talk to people about their experiences, they often make a great deal of sense.
Yesterday, as I was just saying before, we did interview an Italian psychiatrist, Dr. Omberg, and we were discussing with her that it's not a question of how you call it. I mean, as long as the psychiatrist knows what the patient has, okay? It's not a question of how you call it with your patient. Is it schizophrenia? Is it psychosis? What matters is the relationship, physician-patient. The reason why I'm saying this is because the day before we did interview Bent Rosenbaum, and we were talking about the word schizophrenia, disorder, disease, all these things. And he said, okay, one of our patients, when he was told that he had schizophrenia, after a while, the day after, just went into the the forest and he just hang himself up. And, I was just shocked to say, okay, that's, don't say it. But then the explanation by Dr. Homberg just sort of made sense to me. I mean, it's not a question how I call it with the patient. It's that I give hope to the patient when talking to him, and that there is a solution, there is a way out of this. What do you think of this comment by Dr. Homberg?
I think that it's absolutely true that if we understood on a human-to-human level each individual's distress, if we understood that people's problems are understandable, that they make sense in the lives that they live, and that the way to respond to those problems is by working out a solution that makes sense for each individual, that incorporates, to emphasize this, that incorporates an understanding of why the person has developed those problems. Yeah, in that case, then the label that we use is probably much less important. And again, I wouldn't insist that people reject the label schizophrenia or accept the label schizophrenia. What is vitally important is to understand why people have these problems. For myself, I don't think the word schizophrenia is a useful or meaningful term, and personally I would prefer not to use it, but that's a relatively unimportant issue. What's more important is that people take the time to sit down, talk to people, and understand why they're having the experiences that they're having.
Yesterday, Brian Martindale said that this Congress has been attended by 800 psychiatrists from all over the world, and that is indeed a great achievement, considering the topic of the Congress, okay, psychotherapists. What do you think of this?
Yes, I think it's great. I think it shows that there is an increasing understanding from everybody in the professional community and in people who themselves use services that I guess of what we're saying, that we're not just talking about something that just goes wrong in your brain and it needs to be fixed with a drug. That there's much more to it than that, and we need to, as Peter said, have a human conversation about these things and sit down with people and try and work out what's going on and what could help.
Yeah.
Okay. And I don't know how, the things in the UK, but I can tell you that in Italy, there's been a great attention around this meeting. And as I was saying to you, we were just informed by our colleagues in Rome that there was an article and also some pictures which were passed on the Rai News 24, which you mentioned that you know. So there's a great attention. There was a great attention around this, and in particular, you look surprised.
I know, I'm surprised.
And in particular, we know that the sessions run some Italian psychiatrists have been presented, the so-called Teoria della Nascita by Massimo Fagioli. They were even streamed live to Italy, and that they were viewed by 100 people, which were the total of the people that attended the Congress here. So just before ended up our discussion, just want to know whether you have ever come across these psychiatrists, in particular, whether you have ever heard or read about Teoria della Nascita, the birth theory by Massimo Fagioli.
Personally, I haven't. I think one of the problems that we have is that certainly English language academics tend only to read English language publications. I think it's a great failing of my country's education system that people like me are very unlikely to read material in other languages. And sure. Even when people write in English, we're very parochial about our reading. And what we need is many more opportunities for sharing ideas across cultures. No, not in English. I mean, people from different countries coming together in international conferences. We meet perhaps less often than we should.
I know that these psychiatrists, Italian psychiatrists, will be presenting their papers at the next ISPS meeting in the UK.
In Liverpool?
And in Liverpool, and they've already translated an abstract, a short summary of the main book by this psychiatrist.
Great.
And just last question for you. I just want to understand, we discussed about this, but I want you to tell me why you've chosen this picture for your report, because it was beautiful, it just struck my attention so much.
Okay, I guess it was because, normally when you get a report on schizophrenia, it has like a picture of a neuron in the front, or a brain, or at the very most, if it's a person at all, it's somebody on their own sitting, clutching their head like this. We have a phrase, head clutcher, in the UK, all of which are very negative, depressing pictures, which arguably kind of promote the unhelpful message that we were trying to challenge, that these things are always very scary, they ruin your life, and you should be very, very afraid, and you need a technical solution. So the images were, we were trying to select something that was kind of the opposite of that, really, that gave the idea that psychosis doesn't necessarily have to be frightening, because that's one thing that we said in the report that we haven't mentioned actually, is that for some people who hear voices, it can be a really positive experience. So it's not always negative at all, but certainly that there is hope, and that
That's right.
there is hope.
It is hope.
And ordinary.
Yes,
These are
and very
just
ordinary.
lovely ordinary pictures.
Yeah.
Thank you so much. It was a pleasure. Thank you.
And for us, thank you. It was a
Thank
real
you.
pleasure.
Thank you.